now listen, a very nice presentation of something new. Something new, and Hortense Manjo is going to present it. She's a project management specialist with over a decade of experience in managing projects and leading teams. She was the country program director of the first KMC Development Impact Bond in Cameroon. Probably you don't know what is a DIB, and I think that we are going to learn how it was created and developed in Cameroon between 2018 2020, no? 2020.
2019, 2021.
19, 2021. Okay. Hortense.
So thank you very much for the organizers of this Congress for inviting me. And I would like to start by describing the picture. And for me, that explains the reason why we are here. That is the kind of smile we want to see on the faces of the mothers when they leave the hospitals and when they come back for follow-up. So this picture is a picture of one of our mothers who was coming back for her follow-up appointment for one of her baby. And she was really, for us, one of the advocates of our kangaroo. And we thought that it would make justice to have a picture up. So I will be sharing lessons that I've learned from the scale-up of kangaroo mother care in Cameroon based from an innovative financing instrument. And we have heard in the last 3 days many experiences and evidence around the benefits of KMC. And I was very happy when Natalie approached me to talk about how we can make this happen and replicate it in different countries, given the different complexities and contexts where we find ourselves. So I'll begin by sharing some information around Cameroon. So Cameroon has a population of 24 million. We have neonatal mortality of 26 per 1,000, which takes us to about 20,000 newborn deaths in Cameroon every year. And this, for the government and its partners, was the main challenge. And of course, the solution for a low-resource setting like ours was KMC. And no need to preach to converted Christians around the benefits of KMC and how this can be instrumental in changing the face mortality and morbidity in Cameroon. So why was this Kangaroo Mother Care Development Impact Bond designed? Several reasons. To train public health staff to deliver quality KMC. The second reason was to equip the hospitals to be able to deliver, to provide the quality that we want to see. Third was to embed the practices and knowledge within the Cameroon healthcare system. And this was one of the ways that we thought that would ensure sustainability beyond the life of the program. The fourth reason was to demonstrate a transformative approach to service delivery. And this was not meant to demonstrate the effectiveness of KMC, but was more around using the train-the-trainer model to scale KMC in Cameroon. And of course, what we want to see at the end, improve health outcomes for all our low birth weight and preterm infants in Cameroon. Like Natalie said, for the benefit of those who do not know what a development impact bond is, a development impact bond is a performance-based investment instrument that is intended to finance development programs in low-resource settings. And these are very similar to what is a social impact bond, which is widely used around Europe and most developed countries. But again, this is an opportunity to bring in public-private partnerships to fund effective social services through performance-based contracts. And for us, it was very important that we begin to see how we can use private equity and use other agencies that could be interested in investing in interventions that have proven to be effective, especially in the context like Cameroon. So I will start by saying it was very important for us, and it took quite a long time to be able to determine what our objectives are and what we will be able to get payment for as a Kangaroo Foundation Cameroon. So our payment scheme was around 3 different focus areas. So the first is the number of hospitals that are appropriately equipped and trained to deliver quality KMC. So for this program, we had 10 hospitals. I'm going to show you a picture of where these hospitals are located. But then it was not just a hospital, but do they have the equipment that is required? Do they have the staff that are trained to be able to deliver quality KMC? That was a big issue. And here we realized that with KMC, it was not getting the most expensive pieces of equipment, but it was getting the basic minimum requirement, which is already part of the newborn care, really. It was nothing extremely expensive or new other than having the appropriate chairs and beds that could help the mother stay longer or the other caregivers in kangaroo position. The second area of focus was the number of babies that, in our definition, were receiving quality KMC. And this particular area focused in 3 different things. So first, the baby had to be a low birth weight or preterm. Second, that baby had to be enrolled in the kangaroo program. And if the baby is in the incubator room, the baby should be able to do at least 8 hours of skin to skin. If the baby was already in the KMC ward, the baby was able to record it, verified, 20 hours of skin to skin. And the last was appropriate discharge. And our definition for appropriate discharge, long list, but then it just required that the mother and the family and the baby would be able to go home and commit to come back for follow-up, and that the family will be able to take care of the baby and continue to do skin-to-skin care. The last area of focus was the number of babies who come for the appointments right up to the 40th week gestational age, who have recorded at least an increase up to 2.5 kgs, and who have appropriate nutrition. And again, our definition of appropriate nutrition was exclusive breastfeeding or artificial feeding based on the decision of an HIV-positive mother not to breastfeed. So a description of how the structure of the DIB was like. So for some context, Grand Challenge Canada initially funded the Kangaroo Foundation in Cameroon to implement KMC. And based on the results that were obtained, Grand Challenge Canada, for this instrument, decided to be the investor for the program. To my right, you see Social Finance. Social Finance is the organization that helped us to design the Development Impact Bond. And then this up-running capital was provided to Kangaroo Foundation Cameroon, who served as the service provider, of course, with the technical supervision of Kangaroo Foundation Colombia. And we also had, as part of this program, an independent verification agent that was recruited by one of the outcomes donors for the sake of objectivity. And it was only after our results are being verified, both online, physically, and observations were done, that the outcomes funders, Nutrition International and the government of Cameroon, were going to pay for the outcomes. This meant different things to the different stakeholders. So for the government of Cameroon, it was important that we use this instrument to reduce neonatal mortality while ensuring that public funding is used efficiently. For Nutrition International, they found this as an opportunity to incentivize and focus on exclusive or appropriate breastfeeding and weight gain through outcome-based incentive. For KF Colombia and KF Cameroon, for us it was an opportunity to demonstrate that KMC could be effective and that we could we could also be able to implement, to scale KMC within the different contexts and at scale. For Grand Challenge Canada Investor, this program was funded within a particular funding for Grand Challenge Canada, which was named Innovation to Scale. And for them, they were very happy to transition from a grant funder to an impact investor. And this also meant empowering the innovator, who in this case is Kangaroo Foundation Cameroon, to address some global health challenges. Now, to the designer of the outcomes-based model, it meant to explore how to deliver through government hospitals and how this could drive sustainable service delivery. Now, I'm sure those who are interested in scale will want to find out how we made this happen. So for us, it took about 1 to 4 months to be able to establish a team or a program for a hospital. And this meant visiting these hospitals, doing an assessment of the facility, the infrastructure, upgrading the infrastructure. It also meant discussing with the team of the management of the hospital and the neonatal unit to identify a team that has to be trained, and signing a memorandum of understanding which stated very clearly where the roles and responsibilities lie. After this was established, we went on to a 15-day training, which was quite similar to what Kangaroo Colombia would do when they set up a neonatal team, a KMC team. And 3 months after this training, we thought that this is the right time to go back to these facilities and assess them and to see if they're already delivering what we would term quality KMC based on the data that we're collecting. And it was only after we verified and we thought that the quality of the KMC was good that we would send the independent verification agent to begin to verify and collect data for payments. So this is the map of Cameroon to your left, and to the right, we find the different hospitals that were part of this program. So you would see that we had a few hospitals from the northern parts of Cameroon where the mortality rates are highest in Cameroon. We will find some in the major cities of Cameroon with the highest population. And also for regional balance, we had one of the hospitals from the southwest region. And there were some criteria, there was a criteria for the selection of these hospitals. And it was very important for the government of Cameroon to ensure that we have KMC programs for district hospitals, that we establish programs at regional hospitals, but also what we will call in our context a tertiary hospital, because we learn different lessons across these different hospitals. And these lessons range from the composition or the structure of the facility, the context, the customs and the norms of the people, and even more. It's also important to state here that this was done through a phased approach, and we didn't train all the facilities at the same time. There was a time we had to even group district hospitals for the training because we thought that it could create the opportunity for learning. And then after the training, they also kept groups, WhatsApp groups, where they could share experiences. A little bit more information around the project size. We could claim up to $2.8 million of outcomes based on the results that we received. This program was implemented in 5 of the 10 regions in Cameroon. It included 10 hospitals. And for the sake of the definition and in alignment with our national policy, we would define this as the babies that will be enrolled on the program to be those who are less than 2.5 kg. But then we were paid only for those who were under 2,000 grams. And that was because this program was focused on taking care of the very smaller babies. The partners, again, the government of Cameroon, Nutrition International, Grand Challenge Canada. What did we achieve? So in terms of health system strengthening, all the 10 facilities were equipped to deliver our quality KMC verified. We also were able to train clinicians. So in this case, we're talking about doctors, nurses. We had to train physiotherapists and psychologists as been part of our program, and we have our psychologists here with us. We also were able to train trainers, and these trainers were located in different facilities. And for us, this was very important because we had one of our deliverables was to be able to design or to make sure that we had different centers of excellence across the country, which was not achieved because we had different challenges within the facilities to become centers of excellence. But then we quickly renegotiated this deliverable to be having trainers within these facilities that were identified to be centers of excellence. And the last was the training of community health workers to support our KMC hospitals for transfers. So we found that for most of the hospitals where babies were coming too late to the facilities, it became very important to train community health workers to be able to support these mothers, to transport these babies in skin-to-skin position, because this helped or gave us a better opportunity to have better outcomes so that they come in time. So in terms of neonatal outcomes, our major achievement was we had a target of ensuring that we have 951 babies verified to have received quality KMC based on the criteria that I described earlier. We achieved 1,221, so 28% above target. We also were able to see around 80% of the mothers were of the babies were exclusively breastfed, and this number is moving from statistics of about 55 before the program started in most of the facilities. And we also saw that of the total number of babies who came back up until their 40th week appointment, 80% of them had appropriate weight gain at 40 weeks of gestational age. So a deep dive into the results. To the left, we have metric B as one of our indicators, and to the right, we have metric C. I don't have metric A on this slide because it's the number of hospitals that were equipped and trained to deliver quantity KMC, which we achieved. But then what is most interesting is that where we have the dotted lines, that was during the time of COVID. And it's important to say here that, surprisingly, we had better results during that time. I think mothers were very anxious, and everybody wanted to respect all the guidelines and to make sure that their babies receive the kind of care that they would have wanted. But also it's important to say that the different stakeholders decided that when COVID hit, while most outcome-based programs around the world were switching from outcomes-based structure to a grant because they thought that nobody knew where COVID was going to take us. While others paused, the stakeholders were very interested in maintaining the structure of the outcomes-based structure of the program. So the only thing that was absent, or that was taken out in our verification approach, was the observation. And this observation meant that our verification agents couldn't have access to the facilities because that was kind of the national policy at the time. So non-clinical staff weren't having access to the clinics. When it came to the metric C, where we thought that the numbers was going to go down because most of the mothers, while some were very worried about coming back to facilities for follow-up, we decided to do a few things. One of them was create online platforms where mothers would call, and we would also follow up with those who did not come back, and we kind of changed a few things, like following up on these mothers a bit more rigorously than we used to do at the beginning. So yeah, those are the results that we had. And again, in terms of scaling up of KMC, generally, what did we learn? We did learn that an active role of the government was vital. And why was it vital? It was vital because the government was at the front and center of most of these discussions, negotiations, and implementation. We also thought that adapting the service delivery to local context is key because for different facilities, this meant different things. We also learned that multiple carers are needed to provide the number of hours of skin-to-skin that we want to see. So mothers who had twins, triplets, in the beginning weren't able to have up to 20 hours of skin-to-skin. So we encouraged fathers, grandparents, friends to come to support them for skin-to-skin care. And because we're requiring a minimum of 20 hours of skin-to-skin, it was very tricky for most of the mothers, given the fact that in our context, you need to go out for food, you need to go out to pay bills, you need to go out to get your other needs, you need to go out to get showers. And when you put those hours together, it meant if the mother is the main caregiver, it will be very difficult for her to be able to do skin-to-skin for up to 20 hours a day. And the turnover of our clinical staff impacted delivery across different hospitals. And this was because during the 2.75 years of the program, hospitals could move staff from one department to another, or staff could move from one hospital to another. And we had some of our hospitals suffer from this kind of cases. In terms of outbased approaches in health in general, we thought that a regular evaluation enabled a rapid feedback. So every quarter, after the results were being released, we went back to the hospitals and discussed with them. We showed them the results. Together, we agreed on what to do next so that the next verification we could have better results. And this was it really proved to be effective, and it improved the results every time. We also for outcomes-based approaches in health, we thought that engaged cross-sector governance supported the adaptation. So from our steering committee and board, advisory board, we were really engaged, especially when COVID hit, because we could go back and do some alterations. We could go back and negotiate while we all understood the context in which we were working. It was also important for us that the key delivery staff adapt their mindsets. And this was even particular for the staff at the Center of Excellence because this meant doing things differently. And like most of us, change was very difficult for them. But when they began to see the results, most of them were more open to change. There was a clear focus and priority, which was not to measure mortality, but to measure outcomes that could be paid. Because again, we thought that impact was not feasible under 3 years. And we thought that outcomes was what was easier to measure. And also, we had some key points for us. 1 minute. So we thought that we needed clear priorities on what we have to measure. And these measurements were based on the pricing model that was determined within the outcome-based structure. So in terms of sustainability considerations, at the level of the hospital, data capture analysis was key because the hospital should be able to look at their data themselves, analyze it, and see where they are doing well, and also areas of improvement. We also meant documenting KMC protocols and best practices within the teams at the hospitals, and integrating the different metrics within the data information system for the government so that the government will have information that is required to be able to know what they have to do to see change. In terms of health system strengthening, it was important for us that all the staff have access to manuals and training platforms. It was also important that KMC is part of a broader coalition for newborn care. And lastly, that we integrate the different indicators of metrics of KMC in the National Health Information System. So I'll stop there. And for those who are interested in the scale, just have a few slides which just tell us what are the recommendations if you want to scale KMC and what do we learn at different levels. Thank you.
We are late.
So I believe we are very tired and very late, but I think we can accept 3 questions. If there is 3 questions. No more question? Yes, but the one you are the last one, there is no urgent question, but we can do tomorrow too. Yeah, I mean, you can ask us the question and we will answer. Somebody want to say something? No? Yes?
Hello. Yes. No, just to say that perhaps if you agree, we can explore the possibilities for a next Congress to be held in Latin America and the Caribbean. So we can perhaps Uruguay, or we can look for the possibilities if you consider.
No, I think Uruguay and the Latin America Center for Perinatology could be a good opportunity for all the neonatologists of Latin America. No, this makes sense.